Ok, Angélica, vámonos.
Ujú. Bueno, entonces, buenos días a todos los que se conectan. Para quienes no me conocen, pues yo soy Angélica Flet, ginecóloga oncóloga del Instituto Nacional de Cancerología y voy a ser la moderadora del día de hoy. Hoy la Asociación Colombiana de Ginecólogos Oncólogos pues nos trae un invitado muy especial. El webinar se va a realizar en inglés, pero hay traductor simultáneo para quien quiera hacer uso de este. Entonces ahí abajo, en el diálogo de interpretación, pueden hacer el cambio. Lo otro es que por favor les pedimos encarecidamente que se apaguen los micrófonos para no interrumpir pues la sesión y recordar que este webinar va a ser grabado pues en el canal de YouTube. Las preguntas las pueden realizar transversalmente durante la charla en el chat y serán realizadas al final de la sesión. O si lo prefieren, al final, la hora de las preguntas, pues podemos darles la palabra. Si desean, pueden levantar la mano y yo les voy dando la palabra. Pueden realizarlas en inglés o en español. Cualquiera de las dos está bien porque recuerden que va a haber traductor simultáneo. Entonces, a partir de ahora, pues vamos a hacer en inglés el webinar. Okay, so good morning, everybody. Today we have a very special guest. Today is with us Dr. Professor Ranjit Manchanda. He's a gynecologic oncology professor at the Wolfson Institute of the Population Health from the University of Queen Mary in London, and he leads the Women's Precision Prevention Team. He's also a co-lead for the Cancer Screening Prevention and Epidemiology Unit at the Center for Cancer Screening, Prevention, and Early Diagnosis. And he is also a consultant gynecological oncologist at the Bartels in NHS Trust in London. So we are going to talk today about precision prevention in ovarian cancer. So Dr. Manchanda, good afternoon for you. We know over there it's 1 o'clock, you already told us. So we are very honored to have you here today with us. And it is a pleasure for us to be learning from you from this very important subject. So without further introduction, let's begin. And Dr. Manchanda, the mic is all yours.
Thank you very much, Dr. Fletcher, Dr. Pereira. It's very kind of you to invite me to speak at your meeting. It's an honor to be with you. And I'm going to talk a bit about precision prevention of ovarian cancer, something I feel quite passionately about and we do some work in. Am I audible and can you see the slide? Just to check.
Let me see, okay.
Yes.
Okay. So just some disclosures on research funding, just to bring that out before we start the talk, and also to acknowledge various charities and patient support groups we work with in the work we do. So I'm going to cover the background and some facts around ovarian cancer and prevention. I'm going to talk about improving ascertainment, that's risk prediction and picking up people at risk and what we mean by risk and high risk. I will talk about improving targeted prevention and then some future work that we want to take forward and then summarize and of course be open to questions. So this is a big challenge for us. If you, no matter what statistics you look at, and if you look at the IARC data, it clearly shows that the number of cases and deaths from ovarian cancer, whether you look at it globally or you look at it in North America, and the corroborating figures from South America or the UK, it's set to increase. And that's both for ovary cancer, breast cancer, and all cancers for that matter. I sort of coupled a bit of breast with the ovary because often things which are associated with an increased risk of ovarian cancer from a genetic perspective also associated with increased risk of breast cancer. So the challenges before us clearly are the rising cancer cases, the rising cancer deaths, cancer care costs. If you look at data on cancer care costs for or health system costs, you find a hugely increasing trend, which is really not sustainable in the long term if it continues in that way. We also in ovary have late presentation and post survival, and there is I would argue, some financial toxicity in our health systems, especially in the Western health systems. So there is limited awareness around the need for prevention. And I think there's also limited research funding in prevention compared to what you might get in diagnosis and treatment, etc. So our prevention strategy on the research side is based on simple principles. Can we pick up more people at risk? How do we do that? Can we do better prevention, and how do we do that? And what are the strategies we can adopt? And can we do better risk management? And all this can lead to better outcomes from the point of view of reducing cancer incidence and reducing cancer mortality and improving quality of life. So who do we pick up who's high risk? If we look at the various cancers, there are about 20% of ovarian cancers in the general population, and up to 40% in the Jewish population, which is a high prevalence population, are caused by one of these cancer genes. And there's a list of 9 genes for ovary cancer. Some of them you can see are associated with breast cancer, and the Lynch syndrome genes also with bowel and endometrial cancer. There is also arguably now the opportunity to provide personalized ovarian cancer risk estimate using things like a polygenic risk score, your epidemiological and demographic data, and other risk factors. How do we pick up more people at risk or identify them? The 2 approaches both need to go hand in hand. There's a more sort of paradigm changing approach of testing whole populations, and I will explain why I feel that's an important way forward. There is also, we need to do more increased gene testing at cancer diagnosis. That can lead to cascade testing to pick up unaffected relatives who are at increased risk of cancer, whom we can then offer prevention strategies. There is a need to, of course, increase awareness, both amongst the public, but also amongst clinicians. I think amongst clinicians and health professionals, there is limited awareness. And to do all of this, we will need new fit-for-purpose, scalable, large-scale delivery models. We've been doing gene testing in the NHS, and BRCA genes have been around, for example, for 30 years. But we demonstrated some years ago that 97% of these carriers remain unidentified in a large 16 million London population. And I suspect that's the case for the rest of the UK and most parts of the world. So we have approximately 700,000 of these gene carriers in the UK, and we don't know 95% of them at least, despite 30 years of gene testing. That's problematic. If we do know people who are at increased risk, then we can offer them preventive strategies which are very effective for ovary cancer, such as risk-reducing salpingate oophorectomy. I'll talk also about early salpingectomy and delayed oophorectomy later. There's hysterectomy and VSO for Lynch syndrome women because they're at increased risk of endometrial cancer. There's medical prevention, in particular for breast cancer and bowel cancer. And there's more intensive screening for breast cancer and bowel cancer. And our new NICE guidelines also recommends offering increased surveillance for ovary cancer as an interim risk management strategy. All these interventions will depend on the age of the person, the cancer susceptibility gene we're talking about, the risk, issues around fertility and menopause, etc. The Jewish population is a high prevalence population, and 1 in 40 people approximately carry a BRCA gene mutation. And this accounts for about 40% of ovary and 10% of breast cancer in the Jewish population, which is about 2.5 times higher than the general population, where these genes may account for about 10 to 14, 15% of ovarian cancers and about 2.5% to 3% of breast cancers. There is huge underutilization of gene testing, no matter which paper you look at. And there's a lot of papers in the literature now to demonstrate that about 20 to 50% of eligible patients undergo gene testing, not all of them. The family history approach is, we've always traditionally used family history to identify people at increased risk. But I would argue it's a poor surrogate for cancer susceptibility gene probability, because in a cancer or a clinical high-risk setting, more than 50% of carriers are missed by these clinical criteria. If you go into population-based databases, which are now in the biobanks, etc., you will find 70 to 80% of the carriers do not give you traditional family history-based strong histories of cancer, which would identify them. And similarly, the criteria perform poorly in the non-BRCA cancer susceptibility genes. Additionally, in the non-Caucasian populations, whether you're looking at the non-Hispanic Black women or you're looking at Asian populations or other ethnicities, these criteria are, built from Caucasian populations for Caucasian populations, and like any other statistical model, they'll not perform as well in the other populations, and they don't. So they're less likely to identify people at risk in other populations. So it has multiple problems. I put it to you that if you had a test or strategy which misses 50 to 80% of people at risk or people with disease, would you use it? Let's assume you have diabetes and you want to pick up someone who's diabetic, but the diabetic blood sugar test you're using misses 80% or 50% of your diabetics. Is it a good test? I don't think so, and you probably won't use it. But we are doing that using this family history of cancer-based approach when we're trying to identify, just use this methodology to identify people with cancer susceptibility genes. So we're still waiting for people to get cancer to prevent cancer. And switching to a population-based approach can remedy this, or can at least improve our ability and make it more equitable to identify people at risk. And arguably, picking up someone with a gene mutation after they develop cancer is a failure of cancer prevention. So two approaches I think need to go hand in hand. There's a population testing approach, and there's the mainstreaming gene testing of cancer diagnosis, and we need to be doing more of that. So for the population testing approach, we did a lot of work initially in the Jewish population, and we ran a randomized controlled trial called the GCAPS trial in London. And we published a lot of long-term outcome data. There have been other studies also, for example, in Israel, in Canada, in the US also, and in Australia. All of them show, those are all cohort studies, but they all show similar things. So the summary from our studies is that population-based testing in a high prevalence population like the Jewish population is feasible, is acceptable. You would miss 60% of the BRCA carriers if you didn't use this approach. It had high satisfaction. It reduced anxiety in an RCT setting and made no difference to depression and quality of life and the overall impact of the test result. This is we had long-term follow-up in this. The other thing is that we find that people who test negative still go for their routine breast cancer screening, and so it doesn't have, or they don't suddenly start smoking or drinking more or eating more unhealthily. That doesn't happen either in this setting. Also, we showed that it is cost effective to do it for the health system. In fact, it's cost saving in most scenarios. There are not many interventions in medicine that's going to save both lives and money, but definitely BRCA testing in the Jewish population appears to be one of them. So in a summary, we show that population BRCA testing for the Jewish community, the high prevalence community, was feasible, acceptable, had high satisfaction, was cost effective, can save lives and monies, and fulfills the principles of population testing of disease. This then went on, I had an NHS Innovation Accelerator Fellowship, which facilitated the journey towards policy change. Doing research is one thing, but then trying to facilitate policy change or bring it into practice, clinical practice, is another journey altogether with different drivers, and it's got a different context. And for me, it was a big learning exercise again. So scaling up and delivering change is something that happened and took another 4 or 5 years before we managed to get it into our health system, working with the numerous colleagues across the board. I think research was the easier journey than this journey. So we worked also with the National Institute of Health and Care Excellence over the last couple of years. I had the privilege of doing that, and this is now coming to a new NICE guidance. And also the cancer program team, the cancer director, Professor Peter Johnson, and David Fitzgerald, who leads the cancer program work, picked this up as a new cancer program for the NHS, and we're part of an expert advisory group, which is now delivering this across our health system and involved in doing the evaluation of this program for the NHS. So this was rolled out formally at the end of January this year as a new cancer program in the UK health system. So anybody who's of Jewish descent can go and log on to our website. You can do this yourself. You don't need to be referred. It's self-referral. If you have one Jewish grandparent, you can register. You can sign a consent form. You'll get a tube sent to you in the post. You spit in it and you send it back. A saliva DNA-based testing. It's run through our North Thames Genomic Service Alliance, which is delivering it for the whole of England, working with multiple stakeholders. The delivery is led by the ICR team, working also with community charities, including Genetics and High, and my team at QMUL, which is evaluating this program. So it's self-referral. People can review the information, return saliva collecting test. There is telephone counseling, which is available right through this process, where it needs to be initiated for pre-test counseling by the person. For post-test counseling, for anybody who tests positive is found to carry a pathogenic variant, that will happen automatically and be proactively initiated by the program delivery team. Also, cascade testing is available through this program for family members, and GPs get informed of the results. Patients get referred into a high-risk breast cancer screening program and to see the relevant clinical specialists if they're found to carry BRCA mutations or pathogenic variants. So we've had about over, these numbers are a few weeks old, 20,000 registrations and over 4,000 results have been returned so far. And this, as I mentioned earlier, is now part of our new NICE guidelines, which is published in the third week of March this year. So moving away from a high prevalence population, that's the Jewish population, to a more general population, I think testing them for breast and ovarian cancer genes we showed some years ago is will prevent thousands more breast and ovarian cancers and also be cost effective for the health system. This is an analysis for the US and UK health system, which generated a lot of media chatter at that time also. And similarly, we went on to show that both in upper middle income countries and in high income countries, including in Brazil and South America, this would be cost effective for the health system to do BRCA testing for cancer genes. For low income countries like India, the cost of test needs to fall further, more around the $100 mark for this to become cost effective and deliver more societal benefit at a reasonable cost. This is an analysis we just completed for the Canadian health system, working with colleagues from British Columbia, where we show it's cost effective to do this in Canada also. And this will prevent thousands more cancers in breast and ovarian cancers in Canada and will be affordable for the health system. And you can see in a probabilistic sensitivity analysis, 99% of the simulations show that this approach would be cost effective. It's cost effective from the ages of 40 to 60, up to 60 years, but not for someone who's 70 years old. Again, these numbers you can see are well below the thresholds of cost effectiveness of $50,000 to $100,000 per quality. And therefore, this remains cost effective at 40, 50, and 60. We did a pilot study in the UK where a little over 120 women were approached to have population testing for ovarian cancer, personalized risk prediction, including the ovarian cancer genes and the polygenic risk score and other demographic and risk factors. And we used the CAN risk model to provide a personalized ovarian cancer risk. And we showed that there was huge interest, it was feasible, acceptable, had high satisfaction. And in the small sample set, didn't negatively impact psychological health or quality of life. This was delivered through a web-based interface, and user built a decision aid using that, and was very well received by the participants. So it was a proof of principle pilot study. And now we are working on PROTECT-C, which is a general population screening trial for multiple cancer genes. That's the list of the 9 genes I showed you, plus a personalized breast and ovarian cancer risk estimate using demographic factors and polygenic risk scores. I hope by the end of this year, we will be able to start this study. It's funded by Yorkshire Cancer Research. It's a big effort with multiple stakeholders and colleagues, and it's a multidisciplinary project across the UK. We want to build an end-to-end digitized pathway for this. So that's the work we're doing. And we will make this available through web apps where people will be able to see relevant information, watch even videos, consent on the app, and it'll be saliva-based DNA testing sent to your house. You get a result, you're supported by a counseling helpline, and there's a whole range of quantitative outcomes, qualitative, a VUS work stream, health economic analysis, and long-term follow-up built in. So sort of our workflow where people can register, access the app, make a decision on whether they want testing, spit in a tube. They get counseling, of course, if we find that they have positive or a strong family, if they found to carry pathogenic variant. Pre-test counseling is optional and available. If there's a variant identified, they get referred to the genetic services and access the high-risk screening programs. And also cascade testing of the family is available through this process for those who are identified to have pathogenic variants. We have long-term follow-up up to 5 to 8 years. Again, just to acknowledge various colleagues who are working on this project with multiple centers and support groups, including both from the patients, but also some of the Royal Colleges and cancer charities and other universities. Talk a bit about gene testing and cancer diagnosis. Today, we are doing this for sure for ovary cancer, endometrial cancer, and bowel cancer, and that's part of our clinical guidelines. But also, I would argue we should probably be looking at doing this for breast cancer and other solid tumors. This is a paper we just published in the last month on ovary cancer gene testing, saying we should move to multi-gene panel or panel germline testing and not just waiting BRCA testing. And there's some guidelines have already moved there, but I think those which have not need to move towards panel germline testing. We've shown that this would be more cost effective for the health system, would pick up more people at risk and prevent more cancers than just doing BRCA testing. This is an analysis both for the US and the UK health systems involving colleagues across the UK from Manchester, our centre in London, and also in Scotland, Professor Goley's team, as well as this Swisher and Barbara Knocker's team in Washington. We also looked at cost effectiveness for the somatic and germline testing, including the use of PARP inhibitors. And we found that actually the cost of PARP inhibitor should fall by 45% from the list price for it to be cost effective for the health system. But it was definitely cost effective to move to panel germline testing straight away compared to BRCA testing. Our new test directory, that's our Bible for what gene testing is available to everybody in the NHS, does include now a panel germline for ovarian cancer genes, this last iteration. This is a study we ran some years ago in London where we offered both parallel germline and somatic testing. So one of the things that has been discussed in the literature and has evolved is what strategy to use to do mainstreaming for ovary cancer. And some people have been doing a tumor first approach. Some people do a germline first approach. We prefer to do a parallel approach. For us, it should be parallel germline panel testing and somatic testing, where you can do BRCA as well as an HRD. The reason to do both is that if you did only a somatic first approach, you will miss germline large genomic rearrangements because they are less likely to be picked up just on the tumor test. So there is more discordance in the testing, and not doing panel germline misses a proportion, 3 to 4% of carriers in other pathogenic variants that you will miss. We also found that people, depending on where they are in their treatment pathway, need different levels of information. Those who are going through treatment want less, but those who are in remission or just on routine follow-up, they want more detailed information. Therefore, you need to tailor the information needs depending on where they are in the treatment pathway. Our NICE guideline was published in March this year, and we've revisited the threshold at which we should offer gene testing into ovary cancer diagnosis, and also the probability threshold to offer it to relatives. The traditional standard of care was to offer this at a 10% probability. So anybody with ovary cancer clearly would have at least 10% probability of picking up a cancer-susceptible gene and should be offered the gene test. However, we've shown that this would be cost effective. This is published in the guideline. The details of the analysis is a paper that we're just submitting, but the results and the guidance is published. And we find that at about a 3% probability, even it would be cost effective to offer this. So second degree relatives of people, index ovary cancer patients, second degree female and at least first degree male relatives should have the opportunity to have gene testing independent of whether the index patient was tested or not in this scenario. So this is now the parallel germline and somatic testing is now non-UPGCS and DAGP guideline. To do more gene testing, I think we need cancer diagnosis, and especially if you're going to do in breast cancer and other cancers, we need new scalable strategies, and a direct-to-patient strategy we feel holds promise. Sorry?
Por favor, cierren los micrófonos. It's okay, Dr. Manchanda. Continue.
Okay. So this is an RCT we're running where we block randomized direct-to-patient testing and saliva-based testing to a cancer clinician-driven mainstreaming for ovary, endometrium, and bowel cancer. It's called the Detection trial, which we just started across the UK, where people can have gene testing at home instead of doing it mainstreaming in clinic. We build a web app through which you can consent or speak to a counselor, also get information on it, on the pros and cons of testing and watch videos, etc. Talk a bit about surgical prevention. Surgical prevention, we know risk-reducing salping oophorectomy or RRS is the most cost-effective and most effective, clinically effective way to prevent ovarian cancer. We showed you could offer this at a 4 to 5% lifetime risk threshold, and you will save 7 to 10 years of a woman's life. This is now there in a nice guideline, and we would offer anybody with more than a 5% chance of getting ovarian cancer in their lifetime an opportunity to prevent it by removing the tubes and the ovaries. It's also there in our UK Cancer Genetics guideline and an RCGOG scientific impact paper, which we published a little while ago. So how does it differ from what was traditionally a 10% threshold? About 60% of ovary cancer cases occur at over a 5% risk compared to 1/3 ovary cancers over a 10% risk. So there is the opportunity to prevent many more ovarian cancers by using this threshold. Of course, we need to identify the people over that level of risk, and we are not quite there as yet in that, but we're making strides in that direction. And the CAN risk model, which is a personalized ovarian cancer risk model, and there are others also now in the literature which are coming up. It's a validated model which is validated in the UK CTOX cohort and can be used to give a personalized risk estimate. So you could stratify the population into low, intermediate, and high risk and offer surgical prevention. So RRSO is effective. It reduces ovarian cancer incidence. It reduces ovarian cancer mortality. It reduces ovarian all-cause mortality. Also reduces anxiety and worry, and can be done by minimal access surgery. The quality of life, there's no change in general quality of life, but there is poorer sexual function and there's increase in menopause symptoms. HRT improves these things, but it mitigates the symptoms, but it's not the same as having your own ovaries, so it doesn't come back to pre-surgical levels. This is a systematic review and meta-analysis on these issues we published a year ago. When you're operating on these women, be careful of the terminal end of the fimbria. If you're diathermy injury to the terminal fimbria end, you see this is what the histology slide looks like, not like this to the pathologist. So they're twice less likely to pick up an occult lesion. So as surgeons, we need to be careful of injuring the fimbria end. It's very important to use a CFIM protocol, and this is, I think, sacrilege if one does, the pathologist doesn't use a CFIM protocol, because up to 1 in 20 will have a stick or an invasive, micro-invasive cancer, which you will miss if you don't. And 70% of these are in the tube, not the ovary. There's a leftover risk of primary peritoneal cancer, which in the earlier literature was 2 to 4% more. Recent UK data from Manchester suggests it's even lower, and we rarely see this, but it's reported in the literature. If you're premenopausal and then there's no contraindication from the breast cancer perspective, it's important to give HRT till about 51. So this is the paper we published in February this year, which really was personalized assessment and a decision analysis, a microsimulation modeling of for each individual ovarian cancer gene, what's the benefit and what age it should be done, and is it cost effective for the health system. So we looked at the various different genes I listed earlier. And just to cut a long story short, there's a table in the paper which you might find helpful. So 1,000 women have surgery, then how many cancers you'll prevent. And we show that it's cost effective for the health system to do this, but also the ideal ages would probably be 35 for BRCA1, 35 to 40 for BRCA2, 45 for PALB2 and RAD51, CRAD51D, and RIP1, that's the other ovarian cancer genes. This is also there in a nice guideline which has just been published, and this is the modeling that went into the guideline. Premenopausal women, of course, go through early surgical menopause, and that causes increased risk of osteoporosis, vasomotor symptoms, heart disease. 1 in 33 women who don't take HRT more likely to die from heart disease. So there's a whole range of long-term health problems that may occur in women who are unable to take HRT or don't take HRT. And this decision-making is often complex, takes time. It's more challenging, and there's more time and effort needed to manage the woman who's otherwise well in her decision-making than, say, your cancer patients. But it's best done through a multidisciplinary team approach, and we work in a clinic where I work with nurses, psychologists, menopause, fertility specialists, and other colleagues interested in this with fellows and CNSs dedicated to this. And we are linked into a monthly cancer MDT also with our genetics colleagues, and we work closely with the breast and the bowel teams in our network and centers to provide a multidisciplinary care for these patients. And this is just a summary of the NICE guideline. You can see there's a nice table there, and the need for multidisciplinary care is also highlighted in the guideline through an MDT. So that's hopefully going forward, multiple centers in the UK will be setting up these MDTs. We know that most of these cancers come from the tube rather than the ovary, and stick is a precursor lesion which can lead to invasive cancer in 6 to 7 years. So early salpingectomy and delayed oophorectomy is now an option for these women, and this is offered within clinical trials. Premature surgical menopause or RRSO in premenopausal women has a much higher regret of 9% compared to 1% in postmenopausal women. And of course, although satisfaction is high all around, it is higher in postmenopausal and premenopausal women. So in my experience, women really fall into one of two major groups. One who are more concerned about menopause, and they tend to opt for now the early salpingectomy, delayed oophorectomy option, and those who are more concerned about maximizing their risk reduction, and for them, clearly RRSO remains the standard of choice because that we know is the most effective way to reduce cancers. We're not quite sure how many cancers we will end up preventing by the early salpingectomy, delayed oophorectomy option because long-term outcome data don't exist. And this is being evaluated in the literature at the moment in 3 big trials at least. We are running the Protector trial in the UK. The TUBA study was run in the Netherlands, which showed clearly benefit on quality, on sexual function and menopause symptoms with early salpingectomy, and the TUBA-WISP-2 study and the SOROC studies are running in the States, the Netherlands, and in Canada. There's a fimbrectomy study also by Eric LeBlanc and colleagues in France, which is running. So our Protector study, we have 1,200 plus women recruited, and we are looking to extend this to about 2,500 over the next 4 years or so. This is some qualitative work which you just finalized from the study, where we find that the decision making around delayed oophorectomy again requires a lot of support, and the timing of this is very important for women. Menopause management is clearly important. It requires specialist advice, and there is increased cancer worry around stick and those who have a stick diagnosis. which hasn't been reported in the literature earlier. So management of STIC is really a conundrum which we haven't nailed well as clinicians as yet. This is just a picture from our collaborators meeting. So what we don't know in residue is reduction in ovarian cancer risk level, the impact on long-term endocrine function, and how best to manage STIC. These three things we need to address going forward. And we do feel that this should be offered within a research study and not outside a research study. One of the things that we find is discordance between STIC and early cancer diagnosis, and clearly the management now view is different for both. So it becomes really important from a pathology perspective to get this right. In our study, in our trial, we have a central pathology review after local pathology reporting, which improves quality control of this. So we are moving to Protector phase 2, where we will extend the recruitment for another 4 years to make the sample size 2,500 to try and address the issue of ovarian cancer incidence. We have currently been evaluating quality of life, menopause symptoms, and sexual function. So I'll stop there by saying that we are moving towards an era of better personalized risk prediction and targeted screening and prevention. And the technological advancements we have allows us the opportunity to do this. Gene testing can be done at scale, and it's got falling costs. We will need context-specific solutions to deliver this at a population level, and we need new scalable delivery models. BRCA testing in the Jewish population was safe, feasible, acceptable. There are now national programs running in the UK and Israel. Population testing in the general population is feasible and acceptable and potentially cost-effective. And we are looking to do this in a large study in the UK going forward later this year. We need to consider, when you're doing population testing, also the impact on the ethical, legal, social implications. Mainstreaming gene testing, we need to do more of. It's there for solid tumors, so ovarian, endometrial, bowel, arguably needs to come in for breast. We published data on that earlier. And again, we also can, also things like prostate and pancreatic cancer, which there's no reason why we shouldn't be doing it there. The delivery models need to be context and health system specific, and it will not be a one-size-fits-all for everybody. RRSO is the most cost-effective strategy to prevent ovarian cancer. We can operate at more than 4 to 5% lifetime ovarian cancer risk. Remember to do a CFIM protocol. Remember to offer HRT to premenopausal women if there's no contraindication. And surgical prevention is complicated. Decision-making requires a lot of support and depends on the age, the gene, fertility, menopause, etc. Early salpingectomy and deleterectomy should be offered within the research trials. There are knowledge gaps to address. We need to understand the biology of STIC better. We need to understand how to manage STIC. Ovarian cancer surveillance needs more research, but it can be offered as an interim risk management strategy using a longitudinal algorithm to analyze CA1 to 5 in our NICE guideline. And just to acknowledge a number of colleagues who work with me and my team at University of London to do a lot of hard work on all these studies. Thanks.
Thank you, Dr. Manchanda, for an excellent lecture. You really gave us a lot of perspectives. Maybe we don't talk so much about prevention as we should. And there are things to do, and we acknowledge and congratulate you for all the work you've been doing on this topic, that it's really, really important. So we have a few questions from the audience. Just to remember everybody that if you want, you can post your questions on the chat also, or you can also raise your hand and we'll give you time for speaking. So meanwhile, we do want to ask you, you explained to us how the Jewish population has been mostly identified, but we would like to know do you have insights of another risk population, just like the Jewish population, that would benefit from this genetic testing in the whole population?
So there are other
population.
There are other founder populations around the world. There are lots of them. You have populations in Poland, you have populations in French Canada, you have a population, the Inuit population in Greenland. We have a population also in Orkney in Scotland here, which has a 1% prevalence of BRCA itself. There are papers published. There's a paper by Furla et al. In 2007, I think, which has a map, and it gives you huge details of lots of high prevalence populations. So I think the Jewish population is probably the most well-studied, investigated, and the most well-known population like that. But we are now, I think, moving into more general population, but there are other populations. There's the Hispanic population also, for example, in North and South America, which also there are some founder mutations which have been described in the Hispanic population. So there are populations there, and there are lots of parts of the world where this has not been studied enough.
Okay.
So one must not forget that. There are lots of part of the global community of humanity where we've just not done this. We've not studied this enough. So I suspect there will be many founder populations. But hopefully, having done that as a proof of principle, we can now move towards more general population testing concept.
Okay, I understand. Dr. Manchanda, we're going to ask you a favor if you can just stop your screen sharing.
Sorry.
It's okay. Okay, so in this same line, like you showed us all the program you have at the Wolfson Institute, but I was wondering if this only applies for Jewish people in the UK or also all over the world, and if you have like strong bonds with Israel, because the most popular Jewish population, you would expect it to live in Israel.
Yeah, I think the Jewish population applies across the world. Yes, we do have strong links and work closely with colleagues in Israel. We have published up with them also. But also I've worked with colleagues in Australia and America, and working with colleagues in Canada at the moment.
Okay. Okay, thank you very much for that. Okay, so we have another question. For instance, what would you recommend like to calculate the population risk for the general population risk for ovarian cancer? Like, do you have established risk platform? Do you use it, or you just go ahead and use like the common known risk factors without having any risk calculation? What do you use for that?
You can use the CAN-RISK model, which is the most validated model at the moment that's available. And that does incorporate various risk factors. At a population level, we're only doing it in research studies at the moment. So I think even in breast, for that matter, it's still within the research context, or the field for breast for population stratification, for example, for mammographic screening, is already being investigated, and there's long-term data available from outcome studies over the last 5-10 years for breast, and there are RCTs running across Europe and the US also on this issue. For ovary, we are looking at taking a large cohort study forward, but you can use the CAN-RISK model. So it's not there in, I would say, in being population level stratification and testing for personalized ovary risk is still within the research arena, but we use the CAN-RISK model for that. But from a risk assessment perspective, if you've got a patient with strong family history, etc., coming into your clinics, then yes, you can use the models, but also there are other more simplified ways using family history and other papers published giving you relative risk, which you can do a clinical assessment of. But the most sophisticated way would be to use one of the available models.
Okay. There's another question. At which age would you recommend the genetic population testing, or is just over 18, whoever wants it, or is there a special age where you do a more like input to offer this?
So when we offer it in the research setting, we would offer it to anybody over 18. Different people at different ages will come forward. So you might find more people come forward in the 30s, 40s, 50s.
Okay.
experience in the Jewish population program, gene testing studies we did, it was more in the 40s that they came forward. But you do get people coming forward really from 18 to 85 or 87 also, 85. So we don't have an upper age limit. The lower age limit is the age limit of gene testing in the health system today. So anybody at the age of 18 can anyway have gene testing in other contexts. So we've not changed that, that age of testing. We're just going with what is the current standard of care.
Okay. There's a question from the chat. Yes, and in women that have a mutation but still don't reach the age for reduction salpingo-oophorectomy, how do you follow up this women? And if you use drugs for like chemo prevention or oral contraceptives or something like.
That's a good question. The oral contraceptive is a good question. There wasn't time to cover it properly. I think so. If they've not reached the age of surgical prevention, so early salpingectomy we do from 30 onwards in our health system. I know in the Netherlands they offer it at 25, if I remember correctly, but we do it from 30. Our rationale for 30 is usually the age, the ovarian cancer risk doesn't begin to rise before 35, and we've kept it 5 years earlier to that. There's no routine follow-up or screening or surveillance that is offered under 35 because you're not at increased risk of ovary cancer. So why put someone to test where there's high risk of where there's chance of false positive result? You just do more harm than good. So I don't think we should be offering surveillance under 35. From the point of view of medical prevention, the only thing there is the pill. The oral contraceptive pill, if you take it for 5 years, can halve your risk of ovary cancer in high-risk women, and up to 30% reduction in low general population level risk women is reported. But it can slightly increase your risk of breast cancer at the same time. And therefore, there's a trade-off there. If you are in the BRCA carriers, there are 2 types of study designs: cohort studies and case control studies. The case control studies don't show an increased risk, but the cohort studies show an increased risk with contraceptive use. I think it's a complicated decision-making process. You need to take various factors into it. If someone comes at a very young age, then the absolute risk of breast cancer is very small. So if it does go up even, then the actual absolute increase, if your risk is 1% and it goes to 2%, even if it doubles, it goes to 2%, it's not much of an increase. So that the absolute increase will be small, and that needs to be then weighed up against the option of other alternatives for contraception. For some people, maybe the pill is the only thing that's going to work. So you also need to then weigh it up against an unwanted pregnancy if you don't take the pill. So the whole issue of contraceptive choice, whether the pill is the right thing for the person, whether other options can work. There's the issue of the absolute increase in breast cancer risk. Then, of course, there's the benefit of ovary cancer risk that you will get for 5 years use. But if the same patient is going to have surgery later on, then there's not much benefit of taking the pill from an ovary cancer risk reduction, because you get the benefit of the surgery later on. So it's not a straightforward decision-making process. I think it needs to be contextualized and individualized.
Yeah, and it's a dialogue with the patient, because we have a lot, maybe in other fields, like they're referred from the oncologist or from the radiotherapist, maybe they have previous breast cancer or something. So maybe before 35, many people they have this fear, of course, of having ovarian cancer. So it's also something that you have to address and speak also with your colleagues, I think, able to not overdo, like you said. Okay, so yes, there's another question. We established that, of course, salpingo-oophorectomy is the recommended approach for BRCA mutated patients. But if you have a patient that they do not want to go within menopause just yet, do you offer then the salpingectomy with delayed oophorectomy? like a
Yes,
standard, or you just leave it like that?
Yeah, I mentioned we do. But we do it in a research trial. We are running a study called the Protector study. I showed it on one of the slides. And
Yes.
we have 42 centers across the UK who are recruiting to that study. And we have 1,200 women plus on the study, and we are planning to increase the sample size to 2,500 going forward. So we do offer it, but within the context of a research study.
Or only the one that denies, like, I'm not going on hysterectomy because I don't want a menopause patient.
So in the
Okay,
study, all premenopausal women who want to have it can have it if they're eligible in the study. Yeah. We are also recruiting women who are having the standard risk-reducing salpingo-hysterectomy because we want to compare the groups, and we also have a no surgery arm in the study. But the majority of people who are coming in, because it's self-selection, there's no randomization, is people who want the early salpingectomy option. So half the people on that study are those who are opting.
But if these women are not included in the trial, you still offer it?
No, I won't do it outside a trial.
Okay. Okay, thank you. Okay, there's another question. Okay, for premenopausal woman that you offer sterilization, do you have programs like for every gynecologist to, instead of making tubal sterilization, did they go on to salpingectomy? Do you offer this, and do you have programs, well-established programs in the I forgot how you say it. For the, instead of going a tubal, just
So I think
contraception, do you offer salpingectomy? Like, do you routinely teach your gynecologist to do this?
I think so. You're talking about opportunistic salpingectomy.
Yes,
right?
opportunistic
In the general population, yes. So I think it's an option that is feasible, that's acceptable, that's safe, that will reduce cancer risk. I think we still don't know what the level of risk reduction will be precisely with opportunistic salpingectomy. Those data are still, robust data are still awaited. There are good retrospective data, but they have lots of confounding. And so, and there's a variation. The Scandinavian studies show anything from 45 to 65% risk reduction with salpingectomy, but it's not opportunistic salpingectomy. It's salpingectomy with someone who had some disease and had a problem and needed to have the tubes out. And some follow-up data, which was corrected for pelvic inflammation, showed a lower level of risk. But there's now emerging data from Canada, which is coming out, which is showing a risk reduction by Professor Hanley's team. We still need follow-up, long-term follow-up data to understand what is the level of risk reduction we're going to get. But definitely, I think it's feasible, acceptable, safe, and can be offered. I think implementation is probably patchy. There isn't a special program for this that I'm aware of in the UK. It is something we are definitely interested in looking at and taking forward. And what we are keen to do is establish some sort of a cohort or registry for this, so we can follow our patients long term. But it isn't quite there. There is an RCT running. I mean, the only RCTs in the world that are running on this today, you can't do an RCT because they won't be equipoised, are in Sweden by my colleague Annika Idal and Edika Strandl, who are running the SALSTER and HOPSA studies that's on sterilization versus salpingectomy and hysterectomy versus salpingectomy. Those outcome data are still awaited, but they are not, but we still don't have data, and it'll be many years before we get the impact on cancer incidence and the precise impact it would have.
Okay. There's another question. You told us about the CFIM protocol, but I wanted to ask if you do that protocol for every salpingectomy in every woman, or just women at high risk or risk over 5% of ovarian cancer.
Yes, every woman who's high risk and has over 5% risk who has a salpingo-oophorectomy or salpingectomy will have that protocol. Not for every opportunistic salpingectomy.
Okay.
So, the prevalence of a stick is really, really low in the general population. So I think it would be overkill to do it in that population.
Yeah, because
But high risk women, yes.
yeah, you're right. Because from the studies from Canada, at first they did for everyone the protocol, and then it was so low that it
Yeah.
wasn't cost effective.
It's not worth it. Yes, you're right.
Yeah. Okay. I wanted to ask also if there is a concern about the onset of early menopause with opportunistic self-injectome. There's some data that they say it's not an issue, but I think there's no prospective data.
I think you are right.
What are your thoughts about that?
Yeah, we don't know the answer to that question. It's not been addressed properly in the literature. There are short-term RCTs which are followed for up to 2 years or 3 years women and don't show a difference in ovarian function with and without our salpingectomy. But that is not predictive of last menstrual period or menopause. So just a short-term RCT outcome cannot predict when you're going to have menopause. So I think those data are completely lacking. There is a paper in the literature showing no difference in consumption of HRT, etc. But on the other hand, there is also paper in the literature showing an increase in menopause symptoms, etc. So, but there is no proper prospective outcome data to address this question at the moment, which has got long-term follow-up. I've been talking to colleagues in Sweden who've been running the trials, and we're very keen to look at actually those cohorts to try and address it. It provides us a unique opportunity to do that. So we're looking for grant funding for that to answer this question. So if anybody knows funding for it, we have a design and a trial to answer the question properly in an RCT setting, but we don't have the money to do it as yet.
Of course. Okay, we have another question here in the chat. Do you give any treatment for menopause after you do a risk reduction salpingo-oophorectomy for patients that have a mutation, but they don't have like a disease still?
Yes, absolutely. So if they're premenopausal, then they will get HRT till 51. I don't operate on a woman without an HRT plan. The patient has before surgery. And we would have a clear HRT plan for the patient. We will also see them post-operatively at 3 months and every year until they get to 50, 51 duration, which we give HRT. So we have a menopause specialist embedded in our team also, and we have clinical nurse specialists embedded in the team who support patients through this. But I think HRT and lack of menopause symptom support has been a big lack in many services. So in our center, we address that by having a multidisciplinary approach and a clear plan for patients who have surgery, and we don't discharge them after surgery if they're premenopausal. We will see them till they're 50, 51.
And what is the perspective of the breast cancer surgeries upon that, upon giving HR for these patients with the risk of developing breast cancer?
If someone's not had breast cancer, then the short-term HRT does not increase your risk of breast cancer. If someone's had breast cancer, it's very different. Receptor-positive breast cancer is an absolute contraindication. Receptor-negative breast cancer, we look at it on case-by-case basis and individualize the decision. There may be a small proportion of women who can give HRT or different types of HRT, even if it's just vagina or something. But those you need to work with the breast oncology team and see what may be feasible or not feasible. But those who've not had breast cancer, then it's safe, and we would give it.
Okay. We have this last question, Dr. Manchanda. Okay. Dr. Puente says, it is very likely in our media that we have patients with BRCA mutations, but they haven't gone through risk reduction salpingo-oophorectomy over the age of 60. So he wants to know if it is worth it to go on the salpingo-oophorectomy. Definitely, right?
I would 75 also.
Until 75, that would be the
age. No, I don't have an age limit. Look, average life expectancy for women is 85. The older you are, the older you live. It'll be someone's 70, then they're going to live more than the average life expectancy, just from a statistical point of view. And if you, depending on the gene they have, they probably have a 0.5% risk a year, residual
Yeah.
risk. That's
But
high
then-
enough to offer it. Or there's a chance they'll get the cancer. It's better than you have to go and operate on the advanced ovarian cancer. That's worse. So
Yeah.
that's a conversation to have with the patient, the pros and cons.
Yeah, and it's a lower risk
Patients
operation.
need to, so we won't not offer it, but we would have an informed counseling and patients can decide. But have I done it? Yes. Do I routinely discuss it? Yes. And do we offer it if the patient wants it? Yes.
Okay.